Hello everyone, myself Dr. Prateek, your ENT tutor. So let's discuss about hearing loss. So there are certain guidelines. One is used in India, that is known as ASHA guideline, and one is by the WHO, that is World Health Organization guidelines. So in India, what we follow is ASHA guideline. So in ASHA guideline, the mild hearing loss is there if the hearing loss is between 26 to 40 decibel. It's in decibel. So 26 to 40 decibel hearing loss is considered mild. 41 to 55 decibel hearing loss is considered moderate. Then between 56 to 70 is moderately severe. Above 70 and below 90, that is in between 71 to 90 or 91, we can say severe hearing loss, and above than 91 decibel hearing loss is considered profound hearing loss. So this is the ASHA guideline which we are using in India. Suppose the patient is having around 55 decibel hearing loss. So what we can say at the level of 55, that is moderate hearing loss. If patient is having 66 decibel hearing loss as interrupted by means of pure tone audiometry, or we can say by means of this audiogram where we can look out at the audiometry lines. So suppose the hearing loss is around 66 decibel. So that comes in the range of 56 to 70. So we can say the patient is having moderately severe hearing loss. What are the WHO guidelines? It is little bit short as compared to guidelines used in India. According to WHO, the mild is same, that is between 26 to 40 decibel. Then moderate hearing loss is at the level of 41 to 60. Severe is 61 to 80, and above 81 is considered profound. So it is at the with a gap of 20 decibel. So above 81 is profound hearing loss in WHO guidelines, whereas above 91 is profound hearing loss in ASHA guidelines, or the guidelines which we are using in India. Now, how to calculate hearing impairment? So what we can do is calculate the average threshold at the level of 500 Hz, 1000 Hz and 2000 Hz. So calculate the average threshold of these three frequency, then reduce by 25 decibel, which we can see the normal difference, and then multiply the amount or the figure by 1.5. So that the result comes out to be the hearing impairment. If the patient is totally handicapped, so what is the formula? The percentage of impairment in better ear multiplied by 5, add on with the percentage of impairment in the worse ear. That's how we can calculate the hearing impairment in total handicap, and in a routine person, by this method we can calculate the hearing impairment. Now let's look out at the different pathology and how much decibel hearing loss they are doing. Suppose patient is having complete external auditory canal blockage. So complete EAC blockage which result in the hearing loss of around 40 decibel. So the patient presented with the VEX, the complete occlusion of the EAC by means of VEX, will have a hearing loss of around 40 decibel. If there is a perforation of tympanic membrane, it can be central perforation, it can be small, moderate or large perforation. So the hearing loss is in between 10 to 40 decibel. Suppose the patient is having ossicular discontinuity and the tympanic membrane is intact. That means tympanic membrane is intact and ossicle continuity is disrupted. There is no ossicular continuity present. So that will give a maximum hearing loss of 54 decibel. It has been asked in the exam. So they have provided the two conditions. The one patient is having the perforation in the tympanic membrane plus ossicular discontinuity. One patient is having intact tympanic membrane with the ossicular discontinuity. So the patient with the ossicular discontinuity but tympanic membrane is intact will have more hearing loss. That is around 54 decibel. Whereas the patient who is having ossicular discontinuity plus there is perforation in the tympanic membrane will have around 38 decibel, or we can say around 40 decibel hearing loss. So just try to remember this point. It has been asked in the exam. If there is complete fixation of the foot plate as happening in the otosclerosis, so this will give a hearing loss of around 60 decibel, which is one of the highest in this table. So complete otosclerosis will have the maximum hearing loss. Now let's discuss what are the natural resonance. There are natural resonant frequency of ossicles, tympanic membrane, foot plate, etc. What do you mean by natural resonance? At certain frequencies, this particular structure will transmit the sound energy maximum. Okay, so they will work maximum at this frequency of sound in simplified form. So external auditory canal natural resonant frequency is 3000 Hertz. For the tympanic membrane, it is 800 to 1600 Hertz. That means if we give a frequency of 1000 Hertz, the tympanic membrane will vibrate maximally, will produce a natural resonance. That means will transfer the sound energy best of its capacity. So middle ear, the natural resonant frequency is 800 to 3000 Hertz. This tympanic membrane resonant frequency has been asked in the exam in 2012. So try to remember this. What about the ossicles? So there are three ossicles, Malleus, Inca, and stapes. So their natural resonant frequency is between 500 to 2000 Hertz. If we talk about stapes, suppose we talking about stapes. So for the stapes foot plate, we can say, or stapes bone, the natural resonant frequency is 2000 Hertz, and that's the reason the patient with the otosclerosis will have a dip at the level of 2000 Hertz, because the stapes bone or stapes foot plate natural resonant frequency is 2000 Hertz, and if this is fixed or occluded because of the otosclerosis, so at 2000 Hertz there will be a sudden dip. Now let's talk about noise induced hearing loss. In short form we can say NIHL. So what is the normal safe limit? It is 85 decibel daily, at least daily for 8 hours, 5 days a week. So normal safe limit nowadays is considered 5 days a week in a day for 8 hours, around 85 decibel. And noise induced hearing loss, it may be temporary. So temporary is because of the auditory fatigue. So that will automatically heal within a gap of 24 hours. If the NIHL, noise induced hearing loss, is permanent, if the patient is working in some industries with a very large sound where there is a short impulse, high intensity sound is there, so that loud sound will ultimately result in damage of organ of Corti. And we all know this organ of Corti is the sense organ of hearing. So damage of organ of Corti will lead to permanent noise induced hearing loss. NIHL, it is generally having the high frequency hearing loss, and acoustic dip is present at the level of 4000 Hertz. 4000 Hertz. So we know otosclerosis, the dip is at the level of 2000 Hertz, whereas in noise induced hearing loss, the acoustic dip in the audiometry or audiogram will be at the level of 4000 hertz. NIHL is more of high frequency hearing loss, and there is a damage to organ of corti, mostly the outer hair cells. As compared to inner hair cells, outer hair cells are more susceptible for any sort of damage because of some external factor. Suppose patient is having some sort of ototoxic drugs, then also the outer hair cells will get damaged first as compared to inner hair cells. So this is all about noise induced hearing loss. Let's talk about sudden SNHL, that is sudden sensorineural hearing loss. What is the definition? So SNHL loss more than 30 decibel over 3 contiguous pure tones. That means like 500, 750,000 or 1500 tones. So 3 contiguous pure tones within 3 days. If there is more than 30 decibel hearing loss, we can say the sudden sensorineural hearing loss. What is the cause? Most common cause is considered idiopathic, that is, we can't find out any cause. Sometimes it is maybe because of infection like the mumps, measles or varicella. Mumps is considered more common, then comes measles and then comes varicella. So what is the treatment of sudden SNHL? Immediately start the steroids. We don't know about the cause, so we may think of some sort of edema or some sort of inflammation going at the level of the cochlea. So what we can give is start the high dose steroids, or we can use the hyperbaric oxygen or carbazole. If we know the patient is having some sort of varicella infection or mumps infection, then we can treat that viral infection. So this is sudden sensorineural hearing loss. Try to remember the definition or the criteria when we can call the condition as sudden sensorineural hearing loss. Then comes the presbycusis. We all know this is age-related hearing loss. Very, very important. So many times it has been asked. So it is age-related bilateral sensorineural hearing loss, which is very slowly progressive. Why this happen? Again, the outer hair cell with the time, with the age, they get slowly damaged or less functional, leading to presbycusis. Not only outer hair cell, auditory nerve, the conduction pathway, etc. The presbycusis, again, there are 6 types. Type 1, 2, 3 is cochlear type. Type 4, which is the most common one, it is the retrocochlear, that is beneath the cochlea, maybe at the level of the auditory nerve. Type 5 is intermediate and type 6 is mixed. Then comes the ototoxic drug, again very important. So there are, generally we remember by the A, V, C, D. This is my A, V, C, D. Try to remember these ototoxic drug by A, V, C, D. A stand for aminoglycosides, aspirin and anti-malarial drug like quinine, chloroquine. V stand for vancomycin, C stand for cisplatin and D stand for loop diuretics like thiazides. Out of these, the aminoglycosides and cisplatin, these are considered irreversible hearing loss or irreversible damage to the ear. So aminoglycosides and cisplatin are causing irreversible damage. Let's talk about aminoglycosides. So aminoglycosides, out of these drugs, the 3 drugs are mainly cochlear toxic and rest of them are mainly vestibular toxic. So what are the cochlear toxic drug? We learn by the mnemonic CAN, K-A-N. So CAN is this, so K-A-N, CAN, which is leading to cochlear toxic, that means decrease hearing. So what is the CAN? Kanamycin, amikacin and neomycin. Remember by means of K-A-N. Then comes the vestibular toxic, streptomycin or gentamicin. So how I try to remember? CAN for the cochlear toxic, that is for the hearing, for the CAN. So it is kanamycin, amikacin and neomycin. Rest of the drugs like streptomycin, gentamicin are mainly vestibular toxic, whereas the CAN is mainly cochlear toxic. And these aminoglycosides are causing irreversible damage. Then comes the aspirin, anti-malarial drug, vancomycin, cisplatin, loop diuretics. So what does these ototoxic drug causes? They generally affecting the basal coil, which is which is connecting with the high frequency sensory neural hearing loss. So ototoxic drugs are causing high frequency sensory neural hearing loss plus tinnitus. What is the treatment? First treatment is withdraw the drug, discontinue the drug intake, then prescribe the hearing aid if patient is having irreversible hearing loss. Suggest him the hearing aid. We can go for the rehabilitation.